Hi, my name is Jim Shear. I've been treating complex regional pain syndrome for about 12 years. Today we're going to talk about graded exposure. This is probably the first video you should watch. It helps you understand kind of the framework that we treat in and how we progress people with CRPS. A little legal disclaimer. I am a licensed physical therapist, but I'm not your physical therapist. So unless I evaluate you personally in the clinic or over telemedicine, I can't give individual recommendations. But please share this information with your physical therapists, occupational therapists, or other medical providers. Let's spread the knowledge and help develop better care for CRPS around the globe. Treating CRPS is like a maze. You start somewhere and you don't ever know where you're going to end up. And it kind of winds and zigzags and it's not straightforward. This is what I like about treating it, but this is also what's very frustrating about treating it too. No one is the same, and I don't treat anyone with CRPS the same. And this is just more a review of that. One thing I can provide, though, is a framework that can help you kind of organize your treatment. So we're going to define some terms. A flare-up is, and we're going to kind of look at this as a line here. The level that they go over, and it just ends up with a positive feedback loop. So they hit a certain level of activity, they hit a flare-up line, and the symptoms just keep getting worse and worse and worse. So we're going to look at flare-ups here, and we're going to look at where is that level of activity. We're going to look at the minimum kind of challenge line. And this has to do with, are we exercising them enough? Are we challenging the nervous system enough to build more resilience, to build more tolerance and durability to irritating stimulus or irritating movements? We're also going to look at challengers. So challengers are the activities that we're doing to threaten and challenge the nervous system. And resources are the things that they're doing, or the active exercises they can do to calm down their own symptoms. Can they focus on their breath? Can they do some nerve stretches? Can they do some visualization? What helps them kind of calm things down? And then finally, self-regulation. So are they able to utilize these resources to calm down their own symptoms? They're not staying in bed, they're active throughout the day, but they're also not doing so much that they're then inactive the next day. And we kind of develop this steady state of activity, and they know when they're going to flare up and they're able to calm things down themselves. So when we start off, or when someone's really severe, because they could actually come in at phase 1, phase 2, phase 3, phase 4. Depending on how long they've had it and how much it's calmed down and what kind of treatment they've gotten. So if they're in here, there's not a lot of room to do anything. The level of them doing nothing at all and doing too much is very, very, very small. So I encourage people to undershoot this. We're just trying to stay steady state here. Hey, can you do these exercises every single day and not flare up your symptoms? And not even really challenge things, but hey, it's a place to start. We're also going to be looking at a lot of things to kind of calm down their symptoms. So we're going to develop trust in a therapeutic alliance. We're going to spend some time listening to the individuals that are going through this process with their CRPS. We're going to encourage hope. At this point, things just feel like there's no path forward. It feels unsurmountable. They've been in horrible pain on and off throughout this time, and it's just awful when it happens, and it feels very unpredictable to them. We're going to build their ability to self-regulate their symptoms 70% of the time. So before they move on to kind of phase 2, 70% of the time, I want them to be able to kind of calm things down themselves. So we're building resources, emphasizing self-regulation. They still might need other medical interventions. They definitely need to be on medication. I do much better when people are on kind of a cocktail of medications than I do when they're not on them. Sometimes I have successfully treated a couple patients with it, but normally it doesn't go well. So normally it's a combination, but we want to emphasize this ability to self-regulate. We want to establish a baseline HEP where it doesn't go up and down. We're not going to notice big changes in functional measures. Their quick dash score, their LEFS is not going to be changing. And we're going to undershoot the amount of activities they think they can tolerate. The last thing we want to do while we're building the therapeutic alliance is flare them up. So we're going to move on to phase 2. We notice, we were progressing them. We were doing these little stair steps. Okay, we're going to go up. We're going to hold you there. Cool, you're more tolerant. We're going to go up again, hold you there. Tolerance increases. We're going to go up again. We go too far. And now they're in bed for a couple days. Or a day. We want to encourage them to do whatever they utilized here to calm their symptoms down. Did they do visualization? Did they do breathing? Did they do nerve tensioners? Did they do other orthopedic self-treatments to help calm this down? Whatever they utilized, we want to encourage that again. We also notice that the kind of range here between doing too much and not doing anything at all starts to increase. So we can start to challenge things. They see the light, they see that there can be some path forward, but they don't really trust it. Before we move on, 80% of the time we want them able to manage their own symptoms. We're going to start to challenge the nervous system. Can you touch your arm a little bit? Can you hold a fork for 10 seconds? Can you just do these little things to start to challenge it a little bit? Start to work on building resilience, building function. We want them to progress by the end of this to doing mirror therapy 50% of the time and explicit motor imagery 50% of the time. I continue explicit motor imagery visualization throughout their care. So I'll get through with the laterality app, and all this graded motor imagery stuff will be talked about in a future level lecture. But I'll continue having them do their visualization, and we'll build into mirror therapy, but we'll continue doing visualization. Functional measures still might not be changing. They're feeling better, they're reporting, they're doing better, but they're not actually able to do more. They're just flaring themselves up a lot less. They may need encouragement on good days to not do too much because they're starting to feel really good. And then we have to kind of hold them back a little bit and put on the brakes a little bit. Or vice versa, on bad days, we need to encourage them not to fall down. So that's what that shows right here. They had a random flare-up. We don't want them to go back to bed rest. So I just had a patient that I'm working with right now, and they cut their leg shaving, and now they had a CRPS flare-up. We had her running down the hall 4 times beforehand. I didn't want to not have her run down the hall. So I think one day we didn't run down the hall. And then the last 2 days I've had her run down the hall 3 and 4 times. So we built up to 4, and then we slowly got back up to 4, but we didn't say we're going to stop running completely. If we had to back down to 1 time, or if we had to back down to half a time, that would be fine. But we don't want to back off completely. We want to encourage resources during this time too, to help encourage them to self-regulate when they have these flare-ups. Hope, they haven't most of the time, but they lose it during a flare-up. Self-regulation, over 90% of the time, by the time they're done with phase 3, before they're ready to go to phase 4, I want them almost all the time to be able to kind of, okay, I can keep this under control. I'm able to function. I know when I need to take breaks. I know when I can push it a little bit more, and I'm not flaring myself up regularly. When I do start to have a flare up, I do some visualization. I do some breathing. I put on some soothing music, whatever works for them to calm things down, and I calm things down. So that's what we want before we go to phase 4. We're going to encourage only taking 1 or 2 steps backwards during flare-ups, which is what I talked about. We're going to encourage them not to do absolute rest. We're going to continue to do explicit motor imagery. We're going to progress challengers faster. They're going to be able to start to do more faster. So this is interesting. Up until this point, I don't care what's going on biomechanically. I don't care what's going on with their strength. I don't care about what's going on with their endurance, their range of motion, how they're moving. I just care about how much am I irritating things, how much am I calming things down. But at this point, we can start to look at, hey, they don't have enough ankle dorsiflexion. Maybe I need to mobilize that ankle. Or, hey, I need to work on the strength in this area. Or, hey, I need to do these snags to improve mobility. But we can start to look at the biomechanics a little bit and maybe start to change some of that. We're going to see an increase in functional measures during this phase. So phase 4, we noticed that, during phase 1, we're going very slowly. Phase 2, it's a little faster. Phase 3, we start to pick up the pace a little bit. In phase 4, we start to really speed up a lot. So that's an important concept here, is that we really start to speed up a little bit. We start to be able to do more faster. This can last several months to several years. My goal is full remission and to have individuals symptom-free. I don't always get that, but that is my goal, and that's what I strive for. It's not always possible though, but I'm gonna see if I can get there. And a lot of the time I can. They should be self-regulating 95% of the time at this point. We're gonna slow them down when they progress too fast. We're going to continue explicit motor imagery before adding scary activities. We're going to progress faster. We're going to be doing, we might be able to do some Graston even, or instrument-assisted soft tissue mobilization, or grade 4 mobilization. So we're able to progress things a lot more. We're going to problem solve exercise classes or gym workouts. And we're going to continue, they need to really continue to take their medication until they're pain-free. That is a common mistake that people make right here, is they're like, I'm feeling pretty good, but I'm not pain-free. They stop and then they have a flare-up. They might start anywhere on the path, and that's a really important concept. Although I do the whole graded motor imagery process, which again will be another lecture for the first 1 to 3 months, every time, even if they're in the later stages. I do the imagine movement, the explicit motor imagery throughout their treatment. So I'll do that for months and months and months, even after I stop doing mirror therapy. Patients can revert to earlier phases and backslide. And this is common throughout the process. And then we just think, oh, we need to be calming things down again. If they have a flare-up, we can try again at a future date. We should also try to work on a different part of the nervous system first. Maybe we're working on exercise. Maybe we can work on their allodynia. So we just challenge them in a different way. We encourage the use of active coping tools. However, it's going to take a combination of passive and active treatments to get the best results. I do a lot of manual therapy. Often it's a lot of manual nerve stretches, but sometimes I'll do mobilization, even grade 4 mobilization on a shoulder of someone with really bad hand CRPS because they have a frozen shoulder on top of that, or cervical or lumbar mobilization. So we'll utilize that. In addition to that, we just want to encourage, hey, did you do everything you could to calm this down first? Are you doing this enough to calm this down on your own? And sometimes we have to kind of emphasize that over getting them out of pain, is finding these tools they can do, because that's really, really important. We're just speeding things up with any of the passive stuff. I will always I'll always start with graded motor imagery, and I'll always try to find resources, even if they're starting at the later stages, just to know we can find things that calm it down. And that's it. I hope you guys enjoyed my lecture. This is the first one. This is where you guys should start. and I hope it was informative. I'm going to turn this into 3 or 4 hours of a continuing education class, but this is really where you guys should start with this.